Good evening everyone. I am Sneha Daga. I am a 4th year MBBS student and we have Dr. Girish sir with us and we'll be examining a mannequin on ascites today.
So this is a mannequin. I am giving the clinical history to you. This is a 53-year-old female who had liver disease in the past.
Okay.
She is already known case of liver disease and ascites. Everything is there. Now she has come to emergency room with distension of abdomen, abdominal pain, fever, chills, rigors. We have taken care is airway, breathing, circulation, everything. All vitals are normal at present. We are supposed to examine her abdomen as a system. Now, you can start now.
Okay, so first we'll start with inspection. So inspection, I can see that the abdomen is distended and protuberant and the skin is a bit shiny here, and then the umbilicus is everted. And I would like to make the patient stand to check for...
Currently, we cannot make the patient stand because it's a mannequin. Otherwise, you have to make the patient stand if possible. Why you want to do that?
To check for dilated veins and portal hypertension.
To check the dilated vessels around the abdomen, around the umbilicus and in the abdomen.
Yes, sir.
That's correct.
So that is caput medusae, and then we go on to palpation. So for palpation, first we'll start with
inspection. You have to also see any scars, sinuses, peristaltic movement, everything, because these patients can have a lot of bruises on the skin, lot of petechial rashes. Everything should be explained there itself. Whatever you see, you have to explain there itself.
Okay, sir. Okay, so
next is
palpation. So palpation will start with liver. So for palpating the liver, we start from the right iliac.
So before going that, you have superficial palpation and deep palpation.
Yes, sir.
Superficial palpation is you are just keeping your hands everywhere.
Yes, sir.
To see whether the patient is having any tenderness, any warmness, all these things. Suppose patient is having right side, left sided tenderness, you are not supposed to examine that part first. You have to examine all other parts, then only deep palpation will be done on that side. Otherwise, patient will not allow you to do anything. So you can do superficial palpation first, then go to deep.
Okay, so we'll start from the right iliac fossa, and since it's a mannequin, but in case of a patient, we'll ask them to breathe so that we can feel it, and slowly we'll go up to palpate liver. But then,
so once you get liver, what are the typical features you are going to express? Like you have a liver coming and hitting your finger or going underneath your finger with each inspiration. How you are going to write that finding?
The borders, the inferior border.
Okay. So you see the border.
Yes,
border is regular, irregular, sharp, whatever it is.
Yes, sir. Then surface.
Surface also same thing, irregular or smooth. Okay, then
apart from that, the
tenderness, that is very important, because in acute viral hepatitis or malignancies, suddenly when it enlarges, the capsule will stretch. So we have to mention whether the liver is tender or not. That is very important. So borders, surfaces and tenderness. And you have to always mention whether the mass is moving with the respiration or not. Because kidneys are not going to move with the respiration.
Okay. So that was about liver, and then
spleen.
Spleen will go from the right iliac fossa diagonally towards
towards the left side through the umbilicus.
Through the umbilicus.
Okay, so you can go like that. Each inspiration,
and then
you forward, and one point you may get spleen. Sometimes, not always. But if you get spleen, again the same thing. Borders, surfaces, and theoretically there is a notch also in the spleen. Again you have to tell whether it is tender or not. Suppose you don't get spleen, what else you can do? You are not getting a routine palpation, you are not getting spleen. What else you can do?
Maybe we can turn the patient
towards your side and hook your finger on the left side and see, or deep palpation on that side and you can see. Because sometimes because of fluid you may not be able to get the spleen. So spleen is over. That is one axis of spleen. Normally spleen grows in either in this direction, some rarely some conditions spleen will grow in straight. So that also you have to complete. That palpation also you have to do it.
Okay. So that will do from.
Then say like this side.
From that side. Okay.
From that side, this side you have to go directly. Okay. Same like what you did for liver. Okay. So that is over. Palpation of liver, spleen. Do you want to palpate the kidney? How do you palpate the kidney?
Palpation of kidney.
Kidney is bimanual. You keep the both the hands like this, upper and lower. Okay. And if you are getting kidney, it will be ballotable. It will move in your underneath in between the hands. It will not move with the respiration. So that has to be done because polycystic kidney disease and all, you can get large kidneys. Here you won't get. Okay. So that also has to be done. What else? So you have done liver palpation. You have done splenic palpation. You have done possible. Suppose there is a kidney enlargement. That is also done. What else? Next is inguinal area. So you have to expose the inguinal area and see what. What else?
Bladder.
Before bladder. Bladder is of course you have to do. What else?
Before bladder.
Hernias.
Okay.
Because any patient who is having ascites will have pressure in the abdomen. Hernias can be opened. Okay. So you have to look for hernias always, both inguinal area and the umbilical hernias. Okay. You are told about bladder. How do you examine for bladder? So you come same like you went for liver, no? Come from top to down. Okay. But in ascitic patient and all, we cannot get a bladder because ascites is full of fluid, no? So you may not clinically get a bladder. Okay. But ultrasound you can do and you can find out. So that is all. Palpation is over. Next is
percussion.
So how do you percuss?
First we'll go with liver percussion.
You can show me what is liver percussion, what is tidal percussion, everything you have to tell.
Okay. So liver percussion starts with.
Okay. So ideally when you are percussing, no, you have to, this is first finger you have to keep it very tightly. Other two fingers you have to lift it up. They should not go and obliterate your percussing area. So you have to lift it up. Okay. And movement should be only here in your wrist. Okay. So you are getting sound, no?
Yes, sir.
Okay. Resonant sound. At one point, you get
dull.
Okay.
Yes,
that is a liver. Okay. So what is tidal percussion?
Tidal percussion.
Suppose in lungs you are percussing here and you are getting a liver dullness.
Yes.
You ask the patient to take a deep breath. Normally, what will happen? The liver will be pushed down. Liver will be pushed down and you get a resonant note there.
Yes, sir.
But suppose there is a mass there in the lungs or effusion there, so that may not shift. Okay. If it is in the lungs, it will not shift. If it is below the lungs, that will shift. Okay. That is tidal percussion. Okay. You can percuss and you can get the liver.
Okay.
Then spleen.
Spleen again will go from.
No, spleen is different. Spleen, suppose you are getting. Spleen means you can go in this direction. Suppose you are not getting a spleen. Okay. What is this percussion called as? Trops area. So trops area you have to percuss and see that trops area is full or not. Okay. If trops area is full means splenomegaly is there. If trops area is empty, then it is the stomach. Okay, gas in the stomach. So if somebody is not having spleen, trops area will be resonant. Somebody is having a minimal spleen, trops area will be dull. Okay. So that percussion is to be done. Next is?
So next is auscultation.
Auscultation. Why you auscultate the abdomen? How do you auscultate?
We'll check for bowel sounds.
Okay, that is very important. You have to check for the bowel sound. One more thing. You have to check for the spleen. Spleen for splenic rub. Liver for any broe. Aorta for again any broe. So at least 4 points you have to auscultate. One is for bowel sounds. One is for splenic rub. Then liver for any murmurs or like hemic murmurs or what is it? bruit.
Okay.
Again, aorta also for bruit. Auscultate these 4 points. And there is something called as Kluwer-Baumgarten sign.
Sorry.
What is that? There is something called as Kluwer-Baumgarten sign.
Okay.
That is a murmur in the caput medusa.
Okay.
But normally we don't do all these things. Okay. Basically, 4 points you have to auscultate.
Okay.
Okay. Now, this patient is having ascites. You have examined him. He has got ascites. Now, tell me some few important things. What is shifting dullness?
Shifting dullness will make the patient.
Okay. First, you percuss from here.
Okay.
Percuss from here. So you are percussing from here. Go there. So at one point you get a dullness. Okay. Now from that dullness you go up 2-3 centimeters.
Okay.
Okay. Now you turn your finger. Now come this side. Okay. So here also you may get a dullness. Okay. Now you have to ideally you have to turn the patient to one side and you have to percuss and demonstrate that fluid on opposite side is shifted to this side, and while you are turning the patient that side, fluid from this side has gone to that side. Okay. This is shifting dullness, and that dullness is called as horseshoe dullness. Horseshoe dullness. Okay. Now you understood how to examine a case.
Yes,
okay.
sir.
Now tell me, what are the other systems you want to see in this patient? What are the other systems? We won't examine in detail, but you tell me any other findings you want to see in this patient?
Maybe a chest X-ray.
X-ray is different. Other findings, clinical findings. Chest, what else you want to see? Chest. You have to look for gynecomastia.
Okay.
Gynecomastia is one of the common thing in males, and breast atrophy in females should be looked for, because chronic liver disease can have such finding. Then lack of hair, chest hair, body hair and axillary hair, everything lack of hair will be there. Then there will be petechial rashes because of thrombocytopenia. Petechial rashes will be there. CNS, what finding you want to look for?
Altered hair.
GCS you have to look.
GCS
and you have to look for flapping tremors. What is flapping tremor? You ask the patient to keep her hands hold like this, and normal person will hold like this, but a person with encephalopathy will have flaps like this. So flapping tremors. And you want to see the plantar reflex?
Yes, sir.
Okay. Some patients with chronic liver disease with brain damage, they can have an extensor plantar. Okay. You want to check the respiratory system?
Yes, sir.
For what?
For the
pleural effusion. They can have pleural effusion. Okay. Because of the hypoalbuminemia, fluid retention, they can have pleural effusion. Okay. We want to check the heart. Okay?
Yes, sir.
Pericardial. Okay. So these are the findings you look associated with the liver disease.
Okay.
Now we'll see what investigation you are going to ask in this patient, and you tell me why you are asking that investigation.
Okay.
So what all investigation you want to ask in this patient?
So complete blood count.
So you want to ask for a complete blood count. Why you want to see a complete blood count?
In case to check for leukocytosis.
Okay, so here the patient has come with high degree fever, chills, rigors. We are suspecting SBP, spontaneous bacterial peritonitis. So you have to check the count, and if the counts are very high, it will contribute to your diagnosis.
Yes, sir.
So CBC should be checked. Platelet?
Yes, sir. Platelet count.
Low platelet can indicative of splenomegaly. Okay. Then you want to check the hemoglobin?
Yes, sir.
So patient can have anemia due to various reasons. It can be due to blood loss in the abdomen, it can be due to bone marrow suppression, hemolysis, so many things. Hemoglobin can be dropped.
Yes,
you want to check a CRP?
CRP, inflammatory marker.
So if the patient is having inflammation, CRP will be high. You want to check the LFT?
Yes, sir.
So what will happen to LFT in chronic liver disease? STOT, STPT will be?
It will be high.
It will be marginally elevated,
yes,
300, 400, 500, 600 in that range. Albumin globulin?
Albumin globulin
will be reversed. Okay.
Yes,
albumin will be lower, globulin will be higher. Normally albumin is higher, globulin is lower. Okay, that can happen. So bilirubin?
Yes, a bilirubin will also increase.
Can also be elevated.
Yes,
okay, so these are the basic tests. You want to check the creatinine, kidney function test?
Yes, sir.
Why?
Okay, because since portal hypertension, so it might affect the kidney, leading to.
What is that called as?
hepatorenal syndrome.
Okay, so creatinine should be checked. Okay. Then you want to check the PT-INR, prothrombin time and the international normalized ratio.
Yes, sir.
So what does it tell you? Suppose it is elevated, INR is elevated. What does it tell you?
So it's a marker.
It's a marker of liver function.
Yes,
okay, if INR is highly elevated, that means liver is not synthesizing the adequate amount of coagulation factors.
Okay,
so that has to be checked. You want to check the potassium?
Yes, sir.
Why you want to check the potassium?
Because of kidney function.
Not because of that, because hypokalemia is a trigger for hepatic encephalopathy.
Okay, sir.
Hypokalemia is a trigger for hepatic encephalopathy.
Okay, sir.
So you want to know what are the triggers for hepatic encephalopathy? One is infection, already this patient is having. One is dehydration. Okay, we may be giving Lasix or something, dehydration. Third one is patient can have constipation. Patient can have bleed inside the abdomen, high proteins in the abdomen. And one of the most important electrolyte imbalance which can trigger hepatic encephalopathy is potassium deficiency. Okay. Now I have told about hepatic encephalopathy. Can you tell the grades of hepatic encephalopathy? There are 4 grades.
Okay.
So you want to check now whether now when we go for diagnosis, we have to write complete diagnosis.
Okay.
So how do you know that patient is in hepatic encephalopathy? Patient is admitted with high degree fever, chills and rigors. You are suspecting SBP. But when you write a diagnosis, you have to write whether the patient is in hepatic encephalopathy or not.
Okay.
So how do you know that? So there are 4 grades. Grade 1 is altered sleep rhythm. Patient will sleep more in the daytime, less in the night time.
Okay.
So you have to ask the detailed history whether he is having more sleep in the daytime. Second grade onwards, patient develops flapping tremors. So you examine, and if you are seeing flapping tremor, then patient is in grade 2 or more hepatic encephalopathy. Grade 3 is altered behavior. Okay. Grade 4 is coma. Okay. So this patient is having fully conscious, he is not having flapping tremors, he is not having altered sleep rhythm. So he is not in hepatic encephalopathy. But if you don't treat the patient may go to hepatic encephalopathy. Understood, no? So basically we have done some investigation. You want to do an ultrasound?
Yes, sir.
Okay, why?
To check for the fluid ascites.
So we want to see how much fluid is there in the abdomen. You want to see what is the size of spleen, what is the size of liver. Everything can be done.
Yes, sir.
You want to do a parasynthesis. Okay, why you want to do?
To check for amniotic fluid if there are any.
Not amniotic fluid, ascitic fluid.
Sorry, ascitic fluid.
Ascitic fluid and we want to see whether there is an infection or not. We are suspecting SBP. If the counts are elevated, if there is very low albumin, if there is culture positivity, then all you can suspect an infection. That is called as spontaneous bacterial peritonitis.
Yes,
okay. If you are pricking the abdomen and producing an peritonitis, that is not spontaneous. Here it is spontaneous. Without any reason, patient is developing peritonitis. Okay. That's why patient is having high degree fever, chills, rigors, abdominal pain, all these things. Okay. So you want to rule out that. Now how do you are going to manage this patient in emergency room? This patient airway, breathing, circulation is taken care. You have to prevent hepatic encephalopathy and you have to take care of all other things. Okay. So start from all the drugs what you are going to give this patient.
First line cephalosporin.
So you want to give an antibiotic cephalosporin,
yes,
third generation cephalosporin.
Third generation. Ceftriaxone.
That is for what?
SBP.
So that is for SBP. So you are given an antibiotic. Second thing,
for renal function, albumin.
Before that, you have to correct all other problems. Okay. So renal function is last.
Hypotension.
Second thing is you have to sterilize the gut. What is the gut sterilizer you give? Rifaximin. Rifaximin is a non-absorbable antibiotic. 400 milligram BD rifaximin has to be given. Okay. Third thing is you want to prevent constipation. How do you prevent constipation?
Laxatives.
What laxative? Lactulose. Lactulose is a non-absorbable sugar laxative, and it will reduce the pH of the intestine so that bacterial growth will not be there. So that has to be given. Next. So you had given an antibiotic to cover the infection. You had given an antibiotic to prevent the growth of bacteria in the stomach. You had given a
for constipation.
Constipation. Okay. These are basic 3 things you will give for this patient. Now next is this patient is having elevated INR. How do you manage that? INR is 5.
Okay.
Because of liver disease. How do you manage that? You have to give FFP, fresh frozen plasma should be given to treat that.
Okay.
Now these are the basic treatment you give. There are a lot of other treatment we are not discussing. Okay. Now should we give potassium or not? Next.
Yes, sir.
Potassium should be always
given.
corrected.
Yes, sir.
But remember, all patients with ascites, edema, you try to give Lasix, that is furosemide. Okay. Is Lasix alone is enough, or you have to add something else?
Albumin.
Along with Lasix, should we add some other diuretic? We have to give spironolactone.
Okay.
Spironolactone, what is the action?
Spironolactone.
What type of a diuretic it is? It is a potassium sparing diuretic.
Okay.
So we have to give a potassium sparing diuretic. At the same time, it is a what hormone it can block? It's a potassium sparing diuretic. Renin, angiotensin, aldosterone.
Okay.
It's an aldosterone antagonist.
Okay.
Here there is a secondary aldosterone excess. Okay, because of the liver disease, kidneys are less perfused. That's why we call it as hepatorenal syndrome.
Okay.
And because of that, patient is having high aldosterone. Okay. That produces more fluid retention. So you are giving a drug to counter that. You are giving Lasix along with you are giving potassium sparing
Diuretic.
anti-aldosterone diuretic, that is spironolactone.
Yes,
Okay.
sir.
So spironolactone also given. How much fluid you will advise this patient? Will you give lot of fluid or less fluid?
Less fluid.
Because we have to restrict the fluid.
Yes, sir.
So 1 to 1.1 liter fluid only enough for this patient. Will you give salt for this patient? This patient may ask you more salt. Will you give salt?
Yes, sir.
How much salt you give? It is not too much. You have to restrict the salt. 2 gram, 3 gram, that's all. We normally take 8 grams of salt, but a patient like this may require only 1 or 2 grams of salt. If you give more salt, what will happen?
The kidney.
No, not a kidney. What it will try to retain?
Electrolytes only.
Not electrolytes. Something else. This patient is already having ascites, pedal edema. So what will happen to the water content if you take more salt?
It will get retained.
It will more retention of water can happen.
Okay.
So that is a problem. So you restrict water, you restrict this one. Now protein. This patient is admitted to your ward. You want to have some biryani or something. What will you advise? What is the advice you are giving? Whether the patient can have protein, whether the patient can have animal protein.
Okay.
Whether will you advise or not? Proteins are restricted. So
Okay,
protein should be restricted in liver disease, especially acute liver disease. Animal protein should be restricted first. Once the patient improves, you can slowly add plant protein, then animal protein, but not in acute phase. So protein should be restricted. Potassium should be given to the patient. Okay. Now, before discharge, you want to do any other investigation for this patient? You want to refer somebody?
Yeah, we'll refer it to hepatology. Gastroenterology. For
additionally, what invasive test you want to do? Any tube that you put inside? Endoscopy. You have to do an endoscopy because most of these patients will have portal hypertension. That may lead to varices, esophageal varices that can bleed at any time. So we have to always advise the patient for a endoscopy to evaluate varicose enlargement or varicose bleed. That can cover future bleeds. Okay. What else you want to do? Anything else you want to do for this patient?
Anything else?
Now you have to advise the patient. If they are taking alcohol, avoid this. If the patient is having any other habits, they have to avoid all these things and try to prevent infections. If you want to give SPP prevention, any antibiotic can be given.
Third generation.
That is for treatment.
Prevention.
Norfloxacin can be tried. You can give norfloxacin. You want to give any drug to prevent portal hypertension or reduce the portal pressure?
HRS, terlipressin.
That is acute phase. That is when the patient is admitted with bleed. To prevent
albumin,
beta blockers.
Beta
blockers can be tried. Like you can give propranolol or carvedilol can be tried. Okay, you are telling about albumin. You are so fond of albumin. Where will you give albumin?
to prevent hepatorenal.
So when you are giving terlipressin, along with that you can give albumin so that intravascular volume will be maintained, so kidneys will be well perfused.
Okay.
But the problem is albumin is very costly. It costs around 100 ml costs around 5,000 rupees.
Okay.
So we cannot routinely give albumin, but in case of emergency we have to try albumin. Because even if you give albumin, what will happen to the albumin? It will be lost in a few days to extravascular compartment, not to the not through kidneys, because this patient is having ascites, no? Third space loss will be there. So that may create some issue. If the patient develops hypotension, how do you manage?
Vasopressin, like non-epinephrine.
So any patient who is having hypotension coming to ER, first you give fluid. You don't think that this patient is fluid overloaded.
Okay.
The problem in the intravascular compartment is fluid deficiency. Extravascular fluid is there. So acutely you give fluid, then you try to give albumin if possible. Then like you told, terlipressin can be started, but that all depends on your initial BP. So initial BP can be built up only with fluids, then noradrenaline, dopamine, whatever you start, that depends on the clinical scenario. So you understood how to manage a case of chronic liver disease?
Yes.
Okay.
Thank you, sir.